everyone. My name is Tatyana Kushner, and I am a hepatologist. I'm an associate professor in the Department of Medicine in the Division of Gastroenterology and Hepatology at Weill Cornell Medicine. Today, I will be talking about some key questions that relate to the pathophysiology and overview of hepatitis B. One question that often comes up is the question of cccDNA. So how do current insights into cccDNA establishment and maintenance, including host epigenetic factors, inform novel strategies for hepatitis B cure, which we're really hoping will be on the horizon in the not too distant future? So cccDNA, or covalently closed circular DNA, is a highly stable double-stranded circular DNA molecule formed in the nucleus of infected hepatocytes. After hepatitis B viral entry, the viral genome is transported to the nucleus where host DNA repair enzymes convert it into cccDNA. And then the cccDNA really acts as a template for all hepatitis B mRNA transcripts and really is essential for the production of new virions and viral hepatitis B proteins. And because it's so persistent in hepatocytes, this really is what underlies the chronicity of hepatitis B infection and is a barrier to cure because current antiviral therapies that we have available to us really do not eliminate cccDNA from infected cells. The cccDNA is highly resistant to degradation and can persist for the lifetime of the hepatocytes. So it allows hepatitis B to reactivate even after apparent clinical resolution or suppression of viral replication. cccDNA acts as a mini chromosome in the hepatocyte nucleus, so it's subject to host chromatin remodeling and epigenetic modifications, and these modifications regulate the transcriptional activity of cccDNA and therefore regulate viral antigen production and replication. And so really, in order to achieve more durable hepatitis B cure, we need to find ways to address this cccDNA, both through direct targeting of the cccDNA and perhaps through host epigenetic regulation targeting. And although many of the strategies that are currently under investigation to target cccDNA are quite early, there have been some early successes in addressing the cccDNA in patients infected with hepatitis B. The different strategies that have been used, I'll talk about. One is epigenetic silencing of cccDNA. So could small interfering RNAs perhaps be used in combination to induce durable epigenetic repression of cccDNA? Also, direct cccDNA targeting has been attempted with small molecules that have demonstrated some ability to reduce cccDNA, again, in early preclinical models. There's also been a lot of attention to gene editing technologies, so CRISPR and related systems. And these systems can influence the epigenetic state of cccDNA and can really target the cccDNA to minimize transcription of the cccDNA. And finally, host factor modulation. So can we target host proteins that can then in turn regulate cccDNA transcription? And this would offer another avenue for functional cure by silencing cccDNA without necessarily eliminating it, but silencing its activity. So as we think about these different strategies, it will be important to understand which of these strategies can move forward from preclinical models eventually to the bedside. Another interesting aspect about hepatitis B is the interaction between the virus and the immune system. And really, this interaction is very important in regards to implications for disease progression, but also for therapeutics. So a question that comes up is how these immune viral interactions really work in order to dictate chronic hepatitis B progression, fibrosis, and development of hepatocellular carcinoma. So again, hepatitis B is a very immune responsive virus. Really, these critical immune viral interactions are what lead to the development of advanced liver disease, cirrhosis, and HCC. And what we've learned about hepatitis B is that there is a really high burden of hepatitis B surface antigen exposure. And as a result, that actually leads to immune exhaustion. So it leads to T cell and natural killer cell exhaustion by upregulation of immune checkpoints such as PD-1. And chronic hepatitis B infection is characterized by this impaired hepatitis B specific T cell response. Really, there's immune exhaustion, T cell impaired responses, which leads to the continued replication and of hepatitis B virus and progression of disease. And this immunosuppressed microenvironment is what promotes viral persistence, progressive fibrosis, and the development of hepatocellular carcinoma. So when we think about this immune suppressive microenvironment, what can we do in order to wake up the immune system in order to help to target the hepatitis B? Well, certain efforts have been made to target the immune checkpoints that lead to this immune exhaustion. For example, the PD-1 or PD-L1 axis. And they have shown some promise in restoring antiviral T cell function. But what we've learned is that clinical efficacy with these agents is typically highest when they're used in combination with direct acting antiviral agents. So agents that can reduce the antigen load, that can then stimulate the immune system with the additional help of targeting these immune checkpoints. Additionally, studies have looked at therapeutic vaccination that can prime specific T and B cell responses against hepatitis B. And other additional approaches that have been investigated include infusion of neutralizing hepatitis B surface antibodies that can target the surface antigen. And also other mechanisms have also addressed looking at activating the innate immunity and specifically transferring engineered T cells that specifically target the hepatitis B. And all of these strategies really aim to overcome this immune exhaustion that we see with hepatitis B, reduce viral antigen burden, and restore immune-mediated control. But when we think about these immune mediating agents, we also need to be aware that when we target this immune system, that it can also lead to immune mediated liver injury and perhaps even other immune mediated injuries. And therefore, we need to be careful as we move forward with targeting the immune system to also make sure that they are not only effective at waking up the immune system, but safe from an immunologic perspective. Another interesting question that comes up in the field of hepatitis B is the question of extrahepatic manifestations. So what are the proposed mechanisms, the diagnostic challenges, and the management considerations for hepatitis B significant extrahepatic manifestations? So the first question is, what extrahepatic manifestations are there? I would say in clinical practice, we don't see them in the majority of our patients with hepatitis B, but it is really important to be aware of them to recognize them when they do occur. Ones that are commonly described with hepatitis B include types of vasculitis, such as polyarteritis nodosa or cryoglobulemic vasculitis, arthritis. There are some dermatologic manifestations that we can see, neuropathy, hematologic manifestations such as an increased risk of non-Hodgkin lymphoma. And also another important aspect of extrahepatic manifestations is patient-reported outcomes such as quality of life and psychological symptoms that may be related to hepatitis B. In regards to proposed mechanisms, a few of the ones that I mentioned earlier, such as vasculitis, are really related to immune complex mediated injury. So there are circulating immune complexes containing hepatitis B antigens, antibodies, and complement, which deposit in tissues outside of the liver, such as blood vessels leading to vasculitis or kidneys leading to kidney disease. And so the immune mediated response to hepatitis B is what leads to some of these manifestations. There are certain diagnostic challenges that come along with them. For example, oftentimes these extrahepatic manifestations may look nonspecific and may actually proceed or occur without overt liver-related symptoms and may even precede the diagnosis of chronic hepatitis B. So really, in order to make this diagnosis, you should have a high index of suspicion. And when you have the suspicion, to make sure to test for hepatitis B in someone who presents with, for example, vasculitis or glomerulonephritis, kidney disease that may be related to hepatitis B. In regards to management considerations, really the main approach to management here is controlling the hepatitis B and using our available agents to treat hepatitis B as indicated. And in certain of these contexts, you may not choose to use immunosuppressive agents that may be used in, for example, vasculitis or other diseases in other contexts, because you don't want to increase the risk of reactivation of hepatitis B. In regards to the question of psychologic and patient-reported outcome-related extrahepatic manifestations, I think it is important to discuss these symptoms, although sometimes it's difficult to disentangle whether these symptoms are related to hepatitis B or not. However, again, treating hepatitis B per guideline recommendation would be recommended here. And the last question that I'll address today is the question about hepatitis B genotypes. So how do hepatitis B genotypic variations influence natural history, disease progression, hepatocellular carcinoma risk, and differential therapeutic response? So there are multiple hepatitis B genotypes. There are 10 from the letter A through J. And we know that their prevalence across global geography varies. So genotype A and D are more prevalent in North America and Africa, whereas genotype B and C are more common in East Asia. We also know that genotype influences disease activity and disease progression. So genotype C and D are linked to higher risk of disease progression to advanced liver disease or cirrhosis and hepatocellular carcinoma compared to genotype B. In addition, genotype C also is associated with a higher prevalence of basal core promoter mutation, which in turn is also an independent risk factor for HCC development. Whereas genotype B is a more mild form of disease, and it's associated with earlier surface antigen seroconversion, lower risks of perinatal transmission, and generally slower disease progression. Similarly, we have learned that certain genotypes are more responsive to certain treatments. So we've learned that genotype A and B respond better to pegylated interferon treatment, and they're more likely to achieve surface antigen loss in the context of interferon treatment. On the other hand, the medications that we most commonly use for hepatitis B, the nucleoside-nucleotide analogs, genotype really has no impact on response to these agents or disease progression in response to treatment with these agents. So the question becomes, when do we use genotype testing in clinical practice? The guidance from AASLD is not very strong, but it does suggest that if you are considering pegylated interferon treatment, you can consider genotype testing to help to predict who will respond better to interferon. Okay, I will end there. Thank you so much for listening.